background. Okay. So actually, our first presentation will be adapted to surgeons who doesn't like a lot of technical details, but you need to know the concepts of what you would expect to have if you have a service of neuromonitoring. I'll do my best to make it as simple as possible and at the same time as comprehensive as possible. This will be a background about the whole field. What can we provide to you? And you can select from this menu what you like to have in your surgery so that it will be adapted to your cases.
It's coming.
Yeah.
It's coming because it's like
This is not working. Not working. Okay, so by end of this presentation, you will know more about the blood supply of the spinal cord from neuromonitoring perspective. The basics of available neuromonitoring modalities and how to integrate this service into your surgery. I hope you agree with me that neuromonitoring is not a luxury. If you have such case and you have to operate on it, it's not a luxury and it will make real difference for the safety of the patient and for you as a surgeon. Also, if you have such case with destructive spine disease or spinal tumor, spinal cord tumor, either intramedullary or extramedullary, I don't think any spine surgeon will feel safe if you proceed with any of these cases without having neuromonitoring. By having neuromonitoring, you can monitor the possible irritation during tissue manipulation, especially in the motor roots and peripheral nerves. Spinal cord irritation might not be so sensitive in neuromonitoring. You can detect any ischemic or mechanical spinal cord insult. We can guide you to the extent of tumor excision, where are the healthy tissues and where are the pathological tissues. You can recognize functional neural tissues. The classic model here is tethered cord, when you like to recognize phylum terminal and you need to know if you are going to sacrifice something important or not. You can predict, or we can predict, if any morbidity, if happened during surgery, will it be short time recover or not. To give you this, the intraoperative neuromonitoring is a very special service that cannot be midway. It must be excellent to give you all this. It must be very sensitive to ischemic and mechanical injury so that it will give you alarm early enough to do corrective action. Else, if it's not early enough, it will be too late to do anything. It will be over. So to be protective, it must be very sensitive. Must be specific to surgery-related insults so that you will not be bothered by alarms about something not related to surgery. From anesthesia, from patient physiology, from whatever, it must be very specific. Also, it needs to be accurate in recognizing structures, so you'll be confident when you sacrifice the phylum terminal that it's phylum terminal. It's not a functional, so it must be very accurate. Without having the three together, the service will be deficient and sometimes deceiving, that you receive some service to improve safety of the patient, while in the same time you are harming the patient by having a service that is not competent. So it must be competent. Blood supply is very critical for the spinal cord function. Starts from the vertebral artery, starts from the subclavian artery bilaterally, then sends branches all through the cord down through the conus, through anterior spinal and two posterior spinal arteries. All through the course, it receives branches, segmental branches. These segmental branches are very important because it's not enough to send an artery all through the cord to supply the conus. So these segmental branches are very important. And if you see here, it comes out from descending aorta, from the posterior intercostal arteries, then sends branches to supply vertebral body, roots, motor, and sensory, and continue to join the anterior spinal artery. And this tributary, this supply of the regional artery is very important to the point that the blood supply of the spinal cord is related to how much efficient is this segmental supply. If this segmental supply is poor, this part, this segment of the spinal cord is under pressure. It has a problem. So it's not a matter of general blood supply of the spinal cord, it's very segmental. If any ischemia happened at any segment due to surgery, it will affect the spinal cord at this particular point. It's important to the point that the artery of Adams-Hicks, as you can see here, when it comes to the anterior spinal artery, it converts the artery from a small size head side to a bigger size caudal side. To that extent, the segmental supply is very important and critical to the spinal cord. This is a little bit more detailed view, but very important. We have a concept called watershed areas. Watershed areas are all over the body. And by definition, watershed area is an area of the body that is supplied by terminal branches from two arteries. So it's in between two arteries meeting at this point, and its blood supply doesn't have a lot of connection. So it's under risk of ischemia if any of these arteries is affected or there is ischemia. So it's the first part to be affected, and in the spinal cord, blood supply is coming internally, mainly from sulcal branches and bile branches, coming from the anterior and posterior spinal arteries. And these two systems are meeting at a point that is already watershed. Unfortunately, it's around the gray zone that is metabolically very active. So this is the watershed generally. This is a watershed area of the spinal cord all through, especially at the area between T4 and T6. So this is the most important area to maintain blood supply for, and it's under higher risk of ischemia in case there is. Need for blood supply is dependent on tissue metabolic activity, and this is logic. Gray matter and synapses have higher rate of metabolic activity and are far more vulnerable to ischemia than spinal tracts because it's axons. Time window of permanent cord ischemic injury was estimated to be plus minus 20 minutes. But don't feel safe after 10 minutes because this is dependent on how much perfusion initially you are giving to the cord, how much mean arterial pressure is there, how would the cord itself, is it previously healthy or not? So 20 minutes is not a safeguard, so you need to do it as soon as possible to reperfuse the cord if there is risk of ischemia. And the earlier you do this recovery, the better chance you will avoid any permanent injury of the cord. So this is very important. By multimodality neuromonitoring, we mean that we are monitoring both sensory and motor. This is what we do. So why we are doing both? Is it enough to do motor only or sensory only? It's not enough because simply in this picture, you can see the territory of the posterior spinal artery and anterior spinal artery. The gray one is for posterior spinal and the yellow one for the anterior spinal. Posteriorly, sensory tracts are going, while anteriorly, we have motor tracts. So if I monitor either, I cannot tell how is the cord is doing regarding blood supply. So it must be multimodality with both sensory and motor functions monitored. Physiologically, there is a concept of autoregulation. And this applies so much to the cord. Autoregulation of the blood supply of the cord is functional only if we supply mean arterial pressure above 70. In this picture, you can see here in the x-axis, mean blood pressure, y-axis, cerebral blood flow, tissue perfusion. At this point, the body starts to work on autoregulation and keep tissue perfusion at stable level despite change in blood pressure. But below 70, the cord will start to suffer. There will be tissue ischemia. So we like very much to have mean arterial pressure above 70 all through the surgery. And as a surgeon, think twice before keeping or asking the anesthesiologist to keep mean arterial pressure below 70 to avoid bleeding for long times. Try to keep it only to the very necessary duration. Now we move to what we do behind the screen and with the patient so that you will know what's going on around you. We use needles, we use stickers, we use screws to connect the patient to our machine through cables. This is a panoramic slide. This is our presentation, actually. This slide is taking us throughout the presentation. It's a panorama for everything we do with the patient. Then we'll take it one by one and give some details about that. This is the patient to which we connect stimulator over the cortex, or sometimes recording, as we mentioned now, and needles to record the response from the stimulator over the brain. Using transcortical stimulation with the screws and needles in the muscles peripherally will give us chance to record what we call motor evoked potentials. That is very important. Meanwhile, on the pathway of the stimulus, we can record what we call D wave, is a direct wave over the spinal cord itself with the same stimulation but different parameters. We don't have to go into details, but as a surgeon, you can know that we have direct wave over the cord and we have MEPs over the peripheral muscles. EMG can be recorded with the same needles in the muscle itself. We call it free run EMG. We can stimulate the peripheral nerve or the root and get response from the muscle. This stimulation can be through the screw or through the hole or through whatever. We can use monopolar or bipolar to stimulate the nerve itself to come out with what we call triggered EMG. Also, we can stimulate peripherally and record centrally. In that case, the screws over the brain will record responses. It will not stimulate like motor, but it will record. So we stimulate peripherally and record centrally what we call sensory evoked potentials. Still, with the same stimulation, we can record peripherally like nerve conduction. And it has some use in OR. Besides, EEG can be recorded with the same screws we are using for stimulation and recording. Two modalities are important for the spine surgeon, are H reflex and bulbocavernosus reflex. We will discuss some details about it by the end of the lecture, inshallah. It's not very famous, it's not very frequent, but still, it's a tool in hand that we can use. Two more modalities will be listed here, only or mentioned, that are auditory brainstem response and visual evoked potential. That is not related to the spine, it's related to the neurosurgery more, but just to complete the list of the modalities we have in hand. This is your menu, and from this menu, we will work with you to come out with the safest protocol for the patient. Of course, for you to understand what's going on, sometimes we take measurement, on what base we are putting screws over the brain. Actually, we use some anatomical landmarks, bony landmarks over the head to estimate the place of the motor area and sensory area, what we call 10-20 system, same used in EEG. This is used to estimate where to put our screws for recording over the sensory area and for stimulation over the motor area. These are the placement for the sensory electrodes, and this is our patient. Looks same. The yellow electrodes are for sensory recording, and the red cable here and blue cable here are for motor. This is a setup of the patient, and if you put this picture over the patient, you will simply find that it's exactly over the motor area and sensory area using 10-20 system. This is the idea, to record sensory and to stimulate motor over the cortical areas related to whatever we like to do using screws, and this is the shape of the screw. Motor stimulation is very important. Actually, motor stimulation is not stimulating the cortex itself, it's stimulating deep in the brain. This is more relevant to the neurosurgery if they have some superficial lesions and they need to work on it. But for spine surgery, it doesn't change a lot, but this is the way the current stimulates the brain to come out with motor stimulation or motor evoked potentials. Starting with the D-wave. Now we'll start our journey with these modalities. It will be so unsophisticated, mainly focusing on the practical point for the surgeon. If you have spinal lesion, spinal cord region, tumor, especially if it's intermedullary, this lesion has a lot of structures going around it. The patient doesn't have deficit. He doesn't have motor weakness. So what we do is that we put subdural recording electrodes, special electrode, of course, below the lesion, like this, and stimulate the brain. So our current will go through the lesion down to our recording electrode. Initially in the surgery, I'll get some response. My rule is to keep this response the same all through the surgery. In that way, I'm monitoring your surgery so that you will not affect whatever functional structures going around the tumor. But what if I have a problem with my machine? Something changes this response, not due to the surgery, due to something else. That's why we need to put another pair of electrodes above the lesion. That is expected to get response irrespective of what you are doing as a surgeon. So if I have a change above the lesion and below the lesion, I will not come to you. I will go to anesthesia, check the patient, whatever, so that when I come to you, the alarm will be really related to surgery. This is the concept of D-wave. It has a lot of advantages. This, how does it look like? It's called direct motor monitor of motor tract conduction. It's over the tract itself. Has nothing to do with the roots, with the nerves. It's used during intramedullary, mainly during intramedullary tumor resection. Some warm saline will help to improve conduction and will help to give better signal. It needs good fixation. As a surgeon, you need to fix the electrode very well so that any tiny movement during the surgery will change the response. And the baseline we use initially cannot be compared to. So it needs to be fixed very well during surgery so that it will not move, and what I get initially must continue. It has the advantage of giving no patient movement. When we stimulate, we don't have to move the patient. It's simple stimulation, it's weak stimulation is enough to give us response without patient movement, unlike the motor evoked potentials. It's not affected by anesthesia because it's direct response. We don't have a lot of synapses to be affected. Recording below T10 is challenging because the tract becomes smaller, so it won't be easy to get response below that level. To interpret any reduction, it's very sensitive to the point that any reduction in D-wave is considered something important, unlike other modalities. If the D-wave is consistent during surgery, any change in it is very important. And if reduction exceeded 50%, this means that we expect a permanent weakness with the patient. This is for the D-wave. Muscle MAPs are the same signal we recorded in D-wave, but we will record peripherally over skeletal muscles. And wherever we like to record, we must have needles. So we need to decide ahead what are the levels of the cord we need to monitor. And this is the response. It's multiphasic response. Again, without going into details, MAPs are same like D-wave, but peripheral with some technical difficulties in getting response because I'm getting response through synapses peripherally to the skeletal muscle. This is what we use to put our needles according to the myotome level. It had the advantage, MAPs had the advantage of giving prompt response to cortical stimulation, stimulus, response, stimulus, response. Unlike sensory evoked potentials that I have to give 100 stimulus to get one response. So MAPs are so prompt, stimulus, response. This is a good advantage. It's very fast response to mechanical injury. If you are working on the cord and you hit the cord, post response, immediately, I can tell you. More sensitive to ischemia than sensories. It causes jerky patient movement. This is the disadvantage. Sometimes this jerky movement is really disturbing you. So you may stop surgery to give us chance to take motors. But we try our best to give the minimal stimulus to get response without bothering your surgical field. It's not ideal for root monitoring because any muscle is supplied by more than one root. So we cannot tell you for sure that the root is okay or not. We can tell you the cord is okay or not, but the root, not sure. It's more sensitive to anesthesia, more than sensory, and it's blocked definitely by muscle relaxants. This is one of the theoretical problems that I hope no one will see, inshallah, that with the movement, with the jerky movement, there is something like biting. That's why we use bite block in between the teeth of the patient. It must be at both sides so that the tongue will not be affected by this movement of the patient. Your rule is to operate with no muscle relaxant because if we have muscle relaxant, we will not get any response. So you need to work without muscle relaxant. You need to tolerate the associated jerky movement we expect while we give the stimulus. You may need to pull the surgery to have MAPs. We need to maintain mean arterial pressure above 70 and to avoid diathermy during stimulation. Whenever we stimulate, you stop diathermy because its noise is very high. It will affect our system so much and it will mask our responses. For interpretation, theoretically, if the response reduced 50 to 80%, this means something if related to surgery. And practically, this is based on the baselines. If we have good baselines, we can monitor very well. But if the baselines are not so good, we may wait till we lost the signal to tell you that there is something or not. But anyway, this is subjective and this is up to the neurophysiologist with you to decide if this is something or not. EMG is another modality. It's like the diagnostic EMG. It's a needle inside the muscle to record whatever going on. If you touch a root, it will stimulate the muscle. So I'll tell you that you are nearby a root. We expect the needles inside the muscles in a patient under anesthesia to be silent, flatline, like this. But if you touch the root or nearby the root, you manipulate or like that, we expect something like spikes. If more severe bursts, more severe short trains, very severe long trains. Frankly, this is not so much we see in spine surgeries, more in neurosurgeries, but still applicable. If you are working nearby the root, I can tell you by EMG if you are doing something harming the root or not. But by this, I mean the motor root. The sensor root, I cannot tell you. I don't have anything in the muscle to tell me about the sensor root. So this is speaking about the motor roots. Its advantage is that it gives immediate feedback of nerve irritation. It monitors depth of anesthesia. Sometimes if I see the patient starting to move his hand, I see EMG from the hand, EMG from the leg. This means the patient is very light and he might be starting moving before the surgeon can feel this. So we use it to monitor depth of anesthesia sometimes. It's not root specific, same like MAP because of the overlap. It's insensitive to nerve ischemia. If we have nerve ischemia, I don't expect to see anything here. It will be silent till the nerve dies in silence. So I can monitor mechanical irritation, but not nerve ischemia. It is sensitive to neuromuscular blocking agents, definitely, because it stops everything related to motor response. Now moving to another modality that is called triggered EMG. By triggered EMG, we detect the response to a stimulus. We detect the response by the same needles, but we detect it after stimulating using an electrode. This electrode can be monopolar or bipolar, according to what I'm going to do. The monopolar is one electrode, one tip, needle that is somewhere around in the wound, and use this monopolar to give current that is expected to spread around, looking for the reference, looking for the needle. So it is sensitive. In the field, it's sensitive, but it's not specific. It will stimulate everything around. So we need this monopolar stimulation. This is different than the bipolar when we use a probe with two tips, active and reference, and the current is in between the two, stimulating only the point where you touch. Is it nerve root or anything else? So the monopolar that is very sensitive and running around, we use it for screw stimulation and for nerve proximity. When I have tumor, I don't know where the nerve, is it nearby or far away? I put monopolar, I play with the intensity I'm using till I get response to see what is nearby me, what is far away from me, according to the intensity I'm using to get response from this structure. On the other side, when I like to stimulate a root, I need bipolar so that I will stimulate this particular structure without stimulating other structures around. So this is the difference between monopolar and bipolar, and both are available. Stimulation can be for the pedicle hole before putting the screw, can be for the screw itself to detect if there is breach or not, and can be for the root as we mentioned. But in this case, we use bipolar, not monopolar. In the previous two cases, we use monopolar. Triggered EMG has a lot of advantages. It's suitable to evaluate nerve root function. We can stimulate the root. So now we can tell you this root is okay or not. It helps to identify individual nerves and roots in the field. We can tell you what it is it functional or not? It differentiates neural from non-neural tissues, same like what we mentioned in the third cord. Is it phylum terminal? Is it functional root or not? Again, motor roots are more lucky. It's luckier because we can detect motor roots much more efficient than sensor roots. And it's more function, it's more important actually. We can detect medial pedicle screw breach, but it's affected by neuromuscular blockers, again, because we cannot get any response from the muscle. It requires nerve exposure to be stimulated. You need to see something to stimulate sometimes. It's affected by peripheral nerve injury or neuropathy. If we have the nerve pathology that is blocking the function of the nerve, if I stimulate, I will get no response because the nerve is pathological, not because you have a problem during surgery. So we need to estimate what we expect with this patient and with this deficit in case he has a deficit. It's difficult to identify sensor nerve roots, as we mentioned. Your rule is to keep the field as dry as possible. This is very important for you as a surgeon. If you decide to use probe, you need to keep the field very dry and touch only the area you like to stimulate so that the current will not run around through the fluid. This is especially important for the bipolar. Never use cautery during stimulation. Stimulate screw axis, not the crown. The axis itself, not the crown. Plan for the levels to be stimulated ahead of surgery, because if you come during the surgery and you like to stimulate the screw at, let's say, L1 or L2, and I don't have a needle at that level, at that time, I will tell you, I cannot. You need to tell me ahead what are the levels you are planning to stimulate using the screw. That's why my standing question for any surgeon, do you like cord monitor or root monitor? Cord monitor, we have our protocol ready-made. It doesn't change a lot because it's a cord monitor, whichever the case. But if root monitor, I will tell him, what are the levels you like to stimulate? He tells me so and so that I'll be ready before the surgery to stimulate these screws. And during the surgery, I will record at which level, right or left, and go with it. So it's different. That's why, as a surgeon, you need to have plan in mind and give it to the neurophysiology team. Stimulation must be done before rod placement. If you put the rod and you stimulate anywhere, the current will go through the metal. So must be before the rod placement. And before we mention this, it's very important to stimulate the screw once you place it. Don't tell the neurophysiologist, I'll place my screws, then I'll stimulate. It will be useless because if you have a screw somewhere affecting a root, it will take half an hour. Khalas, the root is dead now. So you put the screw, you stimulate, takes 10 seconds, 15 seconds. Sacrifice these seconds to get the benefit you need from the neurophysiology. So after each screw, you stimulate immediately after placing. The safe threshold for thoracic vertebra or thoracic screws is around 6 to 8 milliamperes, lumbar 8 to 10 milliamperes. You don't have to bother yourself. We will tell you if this is breach, if this is borderline, if this is safe. Pathological roots may require higher thresholds. If the root is pathological, I cannot apply these numbers. I expect that the root will get response or give response with higher intensity of stimulation. Moving now to somatosensory evoked potentials. This is what we do. We stimulate peripherally and record cortically, and all through the way, we can record responses. And by the end, we get something like this. But to get this, we have to give around 100 stimulation. That takes half a minute, maybe up to 1 minute. If we are lucky, maybe 20 seconds, but not less than 20 seconds, not less than half a minute. So it takes time, unlike the motor response. Stimulus, recording, stimulus, recording. So it takes time. It's not so much sensitive like MEPs. We use the ulnar nerve for stimulation, posterior tibial nerve, or peroneal nerve, or any accessible peripheral nerve we can use. Even pudendal nerve sometimes over the field. This is the response we expect. We interpret it based on the amplitude or the latency, but it's more or less subjective. It's not always we get very stable response in sensory evoked potentials to judge if this is a reduction of 10%, 20%. It needs to be something significant, but we need to be careful because sometimes it takes time to happen. And in this case, you may not recognize that this response, if you see the screen now, look to the screen, this is what happened. See the difference? Over time. So we need to be critical and make sure that nothing is going on in the background and you cannot see. SAPs are not affected by muscle relaxant, so we can work with muscle relaxant, no problem. That's why initially we ask the surgeon if he is doing something not related to motor system and we are not going to stimulate motor system, the anesthesia can use muscle relaxant, and we will be happy to record SAPs because at that time the noise we get from the muscles will not be there. It doesn't cause significant movement of the patient. You will not feel it as a surgeon. It can be continuously running all through the surgery, because it will be only hands and feet are moving. You will not feel anything in the field. It's affected by anesthesia, less sensitive than motors, but still affected by anesthesia. It takes some time to get single response, as we mentioned, a concept called averaging. It's not suitable for root monitoring, because again, any area we stimulate have more than one root, so we cannot make sure. It only monitors large sensory fibers. It doesn't monitor small sensory fibers. It doesn't protect against motor weakness. It can be completely normal, and the patient comes out paralyzed. So it doesn't give safety to the motor system. Your rule in that case is simply nothing. You will not feel anything. You will not ask you for anything. It will be running in the background. You will not feel. H reflex is something related to S1 root. It goes in S1 sensory and comes back in S1 motor. So it's something related to, if you have a surgery related to S1, it's useful to be in our arsenal while doing monitoring. We stimulate around the popliteal fossa. The stimulus goes up and comes down. And this response or this test gives us two responses. The initial one here, that is M wave, and the later one is H wave. We expect the H to come first, then the M to follow. When we stimulate more, we lose the H and we get the M. You don't have to remember this, but it's nice to see it being recorded. In this case, this is H reflex. Here at this point, this is the place of M wave. This is a place of H reflex. The intensity here will start at 12. We'll take it up, then down. When we take it up, the H reflex will come down and the M comes up. When we take the stimulus down, the reverse will happen. You will see it now. So we are taking the stimulus up. The left side M wave start to appear here, and the H reflex to disappear. Then we take it down. The M disappears and the H appears. So this is H reflex. This is a good monitor for S1 in particular. Again, it's not a classic test, but it's there and can help in such cases. Bulbocavernosus reflex is simply diagnostic for spinal shock. When you squeeze the penis, you get anal contraction. This is diagnostic, and it's polysynaptic reflex at the level of S1, S2. Intraoperatively, we do this electrically by stimulating over the clitoris, the clitoral nerve, going through the pudendal nerve up, back into pudendal nerve to the anus. So we stimulate the clitoral nerve or dorsal nerve of the penis. And this response is expected to give me contraction in the anal sphincter and coming with the bulbocavernosus reflex, left side and right side. This monitors a very low area of the sacrum at S2, S3 that is not accessible with a lot of tools in hand. We don't have muscles there. So this is one of the tools that can help with some technical difficulties, but it's in hand and you can see we can come out with something very useful. This is pudendal nerve SAP. With the same stimulus over the dorsal nerve of the penis, we can record pudendal nerve sensory-evoked potential over the cortex. And this is the response that is sometimes useful again at that very low level of the spinal cord. NCD is something we don't monitor except in case we have peripheral nerve surgery. But for spine surgery, we use it to monitor the anesthesia in a test called train of 4. Sometimes initially the anesthesiologist gives the patient muscle relaxant to put the tube. In books, this muscle relaxant should go off after 15 minutes, 30 minutes. Sometimes we see that this is different than what happens on the table. And we sometimes need to run train of 4 to make sure that we cannot get responses mode. We cannot get baselines. Why? In that case, we run this test to make sure that is it muscle relaxant or not, just to document and make sure. The last is EEG. EEG is something monitoring vascularity of the brain that is away from the cord, but we use it to monitor the depth of anesthesia of the patient. And it's really important in any neuro monitoring modality. It must be there to make sure that your patient is deep. That's why responses are low or not. It's good. Even anesthesiologists will like it. Will like to have it running at that time. Okay, we can conclude at this point, and these are the tools we can give the spine surgeon. Other tools are mainly for neurosurgery. This is a background upon which our coming speakers will give you some details with each of these modalities and how to apply in the surgery. I hope it was clear enough. Thank you.